So just so our committee or our folks know, we have a quorum of our full board present, and as y'all know, we moved the committee into a committee at large. So that's why we're now, we've got a different configuration, which then means that all of you can vote now. Before, as you recall, only some of you could, but now everybody can vote. Okay, so if everybody's ready, you're good? Okay, very good. Ann's on board, that's good. Ann, can you hear me? Good to see you, Miss Ann. Yes, it's about 10 o'clock her time frame. I don't think I need that.
Yeah.
But anyway, okay, I'm gonna go ahead and proceed. Good afternoon. Today is May 13th, May 2026, and it is 3:33. It is 3:33. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Strategic Planning Committee. As a reminder, a committee member may also be participating by video conference, and then we, as you all can see, we have Ann Kitchens on video. So the staff will also be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. I would like to announce, in order to make it more accessible to the public, we would like to hold public communication for both Strategic Planning Committee and Executive Committee meeting at this time. If there are any commenters signed up, I will take them now. Do we have anyone? We do not. Thank you very much. All right, so before we proceed with the agenda, I just want to make a couple of announcements tonight for purposes of our agenda. We're going to move what is currently your item number 3 will become item number 4. And then we're going to take items, what will be 4 and 5 will be in closed session. So I'm just giving you a heads up about that, okay? Further, I want to let you know that we have a very heavy agenda, not just for our meeting, but more so as it'll follow into the executive committee meeting. So right now we're currently slated to go all the way to 10 o'clock at night. What that means for us is that we need to be very efficient with ourselves and our time and our comments. That being said, I'm gonna ask you to please be, as we move forward with our presentations, I'm gonna ask you to please be succinct. Don't eat up time unnecessarily if you don't have to. And I'm gonna go ahead and I'll go around and give everybody one opportunity to ask a question or comments. But if I can ask you to please hold your comments, and if you have any other comments that you want to share, maybe you can share them with me later if that's prudent for you. So with that, let me go ahead and proceed with the committee meeting. The first item on the agenda is a review and approval of the minutes of the April 8th, 2026 Strategic Planning Committee meeting. May I have a motion to accept the minutes as presented?
Sadora, I move for approval.
Manager Jefferson moves for approval. Do we have a second?
Second.
I think I saw Dr. Brinson, so I'll go with Dr. Brinson's hand first. So it's been moved in second. All those in favor, please signify by saying aye. Aye. Any abstentions? Any noes? No. Thank you. Then we'll move now to our very first presentation of the evening, which will be the receive and update on Central Health's respite care services. And I believe we have I'm not going to get this right, Dr. Allen. I'm going to call you Dr. Allen for now, since I don't have the last name. I don't have a last name down right. And Dr. Audrey and Megan Rittman. Could you please come up for a presentation?
All right, good afternoon, Chair. I'm Alan Chelsea, CMO for Central Health. Good afternoon, members as well. I'm really proud and excited to be introducing Megan and Audrey. Megan serves as our Director of Transitions of Care and Respite, and Dr. Kwong serves as our Director of High-Risk Populations. And the two of them have really been instrumental in setting up a lot of our high-risk clinical environments. They're going to point to others, but these two have really been central to the success of our patients, and they're going to share a little bit of that journey and which will include some patient care stories. I did want to also take this opportunity to introduce Dr. Beth Schulwolf. Dr. Schulwolf is one of our 2 associate chief medical officers. The other is Dr. Mylinda Zabramba. Both of them are actually hospitalists by training. Mylinda is a family med doc, and Beth is an internal med doc. Beth has been with us for a little under a year, and part of her scope is really the oversight of the respite environment, which is why I'm introducing her. I also did want to share that she has a rich work, academic and clinical history, and prior to joining our team here, she served as Chief Medical Officer for Dell Seton. So she's been a critical add to the team, and we thank her for her wisdom and input. And with that, I'm going to hand it over to Megan and Audrey.
Great. Thank you so much for your time today. We have a lot to share, but I very much want to be respectful of your time and your packed agenda. So if I'm going fast, it is because we have a lot of information, but I always welcome anyone who wants to come for a tour. But we will go through it pretty quickly. Since you have all the slides, I probably won't go through everything, again, to be respectful of your time. But before I jump into the evolution of medical respite at Central Health, I want to first make sure we're all on the same page. So what is medical respite? It is a program that provides a safe discharge for individuals who are experiencing homelessness and who have an acute medical illness. Who gets referred to medical respite? It's someone who's coming out of the hospital or coming from a skilled nursing facility. We also take referrals from our outpatient colleagues, someone who may need a knee replacement or cataract surgery. We also take referrals from our street medicine team and our healthcare for the homeless colleagues. So our involvement at Central Health at medical respite has been 10 years in the making. And while many people in our community said that we needed medical respite, Central Health was the first one to answer the call. So our first iteration of medical respite happened in 2016, where we contracted for beds at a skilled nursing facility, Heritage Park. So at that point, we were just the payer. Our second iteration of medical respite happened in 2022 when we contracted for beds at 2 shelters, A New Entry and Arch. During that 3-year period, we took over 1,000 referrals and accepted 300 patients into our program. We soon realized we needed our own space so we could control the environment. So last July, we opened our own medical respite at the Clinical Education Center located on 15th and I-35. It's a beautiful site. I hope you can come visit. We have a clinic upstairs and up to 50 beds on the first floor. So our presentation will really focus on our experience in the last 8 months at the Clinical Education Center. Next slide. So I really just wanted to share a lot of data. Here's our demographics. You can see gender, identity, age, but I want to focus on the bottom, which is that our population really reflects our community. On the right, you'll see the point in time count from ECHO in 2025 that show individuals experiencing homelessness make up in 32% Black and 26% Hispanic, and that is mirrored at our medical respite, where we admitted 42% Black individuals and 15% Hispanic. This is data of 8 months from the end of July to the end of March, where we had over 300 referrals and accepted 57 individuals. Next slide. So the next slide shows all the comorbidities of our patients, that they may come in for a broken leg, but they also have a lot of other things going on. About half of our patients have a behavioral health need, over 50% have hypertension, a third have diabetes, and you can see all the other chronic illnesses. That really underscores the severity of illness and the complexity of disease that we address and stabilize while they're in medical respite. On the right, you'll see the top diagnosis of individuals who come to respite. The top 2 should be no surprise. Trauma is number 1 with 28%, and then wounds is second with 25%. You can imagine that having trauma like broken leg, broken arms, wounds would not heal if you were living on the street. So medical respite gives an individual a chance to recuperate from these conditions. Number 3 is heart failure. This was also a good diagnosis, a great diagnosis, because we know that heart failure can be reversible if you're taking the right medications and you have care. And then the last, the fourth most common is outpatient surgeries. These are individuals who need their cataract surgery, their hip replaced, they need a place for chemo and radiation. Again, they would not have a place to get these surgeries or get this treatment if it wasn't for medical respite. And then the bottom I want to highlight, this is Dr. Neha Shah. She's our Central Health's first physical medicine and rehab doctor that we are so blessed to have, who works out of our clinical education center. Here she's doing a class on stump and amputation care, and you can see in the picture how many people are in wheelchairs who come to us with those conditions, and her class was very popular, and we're so happy and excited to have her on our team. So then the next slide on the right shows all the different services that they receive when they get here. All of this, all the services listed there on the right are co-located at the Clinical Education Center at our medical respite facility, except for the last one, cardiology. If you look at the third column, that tells you how many patients access the service. So you can see about half of the individuals got to see a dietitian. About a third of them saw wound care, and on average, they had 8.8 visits. About a third of them saw physical therapy, on average 6 visits per individual. 25% received behavioral health. They got to see clinical pharm. They got to see psychiatry. So many of these were to address their acute medical need, but then many of these visits were to also address education and stabilization, so that not only can they be successful on site, but whenever they leave us, that they will have the skills and tools needed to sustain their health. So then after they've been with our program, what happened? So of the 57 patients that came to our clinical education center, we discharged 35. 2/3 of them completed our program. And then about 14% self-discharged and 14% were administratively discharged. But for those who discharged either by self or administratively, they stayed 30 days. I would argue that you can get a lot of good stuff done in 30 days, get some good rest, get connected to care, get a lot of things resolved, and probably they felt pretty good by the time they left. And then I'm also proud to say that compared to our prior location, we had many less people self-discharge and administratively discharge, which is the reason why we decided we really needed our own facility. And then of the 35 who discharged and the 22 who completed our program, nobody was discharged to the streets. I think one exciting thing about our program is that while we are developing our respite program, we are also simultaneously developing our housing program, so that when you discharge, you'll have a menu of places that you can potentially discharge to, which is the first time that we've really had this in our community, that we can match individuals to the right type of housing that fits their needs and that fits their choice. So we had 5 people go into permanent supportive housing, which is the first time in my almost 10 years of living in Austin that we've ever really had that option. And then we also had individuals discharged to our shelters, to family, and to other transitional sites like Esperanza. So this is really exciting. And Megan will talk more about that. Okay, our last data slide, I promise, is the next slide, and that's metrics around additional services. I'm really proud of the clinical stuff that we get to do, but also the non-clinical things. So you can see from all of the services, the top 2, 100% of our patients got case management, 100% of our patients got help with appointment scheduling, follow-up care, and transportation help. And I think that's the number one reason why patients who are experiencing homelessness have a 50% chance that they'll get readmitted, because they don't have the resources, they don't have the phone, they don't know how to make these follow-up appointments. So our team is helping. And you see this second group photo. It's kind of small, but that's our amazing case management team. They are able to help people access our homeless management information system. As you know, to get housing, you have to do a coordinated assessment. We can do that on site. In the past, you'd have to go to another location to get that done. We can do that on site. This team is also accompanying people to the bank, to the Social Security office, talking with parole officers, community case management, and ensuring a safe transition out of respite. And so really shout out to this team. I also want to point out the 5th item down is PCP established. 3/4 of our patients coming into medical respite did not have a PCP, but they all left with a PCP, which is really great, again, to ensure that the care that we're doing is sustainable after they leave. And then I also want to just shout out the 11th item on this, which is resource eligibility. So this team on the top, that's our disability team, which we have at Central Health. We have been able to leverage this amazing team to help us apply for benefits. We were able to refer half of our patients to this team. They saw 26 referrals. We got 8 approved, and 16 are currently pending. And this is really helpful to change the trajectory of their homeless status, that if they can get some income, that really opens the doors for more options. In 2026, this team so far has received over 200 referrals and 77 approvals for disability, which is incredible. The last thing I want to point out is this bottom table. So I would hypothesize that people coming into medical respite, when they leave, they should have decreased hospitalizations and decreased ER visits. And this is a study that we're starting to do to really show that. We're still very early. We didn't have enough statistical power to show a big change, but I do think that we are starting to show that trend. So this is a really elegant study that looks at patients that came to medical respite. This is a cohort study, so patients who came to medical respite, and then we compare them to a control group of patients who got referred to respite, but they couldn't come because there was no bed. So if we had a bed, we would have taken them. So we had two groups, and then we followed them for 90 days. And we found that those who came to respite had a 35% reduction in inpatient days in that 90-day follow-up period. Unfortunately, this was not yet statistical significant, but I think that with more data and more time, we could show that. In fact, this data, it comes from our other phases of medical respite, not individuals who are served at CEC, because we didn't have that longitudinal follow-up. But I think because of the care that we're delivering at CEC, I think it's going to be even greater. Unfortunately, with ER visits, we weren't able to show a decrease, and I think we're looking at the data and the individuals who were served. But I think that, again, there is a trend that we will have across the country that respite does decrease ED visits, and I think it's only a matter of time before we show that. That's more data to come in the future around that.
Next slide. I'm going to talk a little bit about our patients who are moving into housing. You'll see on the left all of our referring partners into medical respite. Medical respite sits in the middle, and then I'm really going to focus on post-respite. How are we supporting our patients? So up until recently, as Dr. Kwong mentioned, most of our patients relied heavily on the coordinated entry process, which is not focused on medical acuity. So many of our patients had long wait times, waiting for housing options, or weren't successful once housed, just given the type of unit they were housed in, and or the type of wraparound support that was provided. So we have now started to work directly with certain housing partners. Our first partnership was with Family Elder Care, where we were able to work closely with ECHO to create a pathway where our respite patients could go directly into a family elder care unit. This allowed us to focus on medical complexity and then prioritize patients who were actually ready to go into housing. This was based off of the relationships our staff have built with patients, where patients are on their medical journey, and then even down to the type of unit that patients might need. Do they need an ADA unit? Do they need grab bars? Are they visually impaired where certain colors might be beneficial? So this allows our patients to go into an environment where they feel stable and are more successful in housing. We also now have a partnership with the Other Ones Foundation, Esperanza Community, that allows for our patients to go into transitional housing. And this allows kind of a runway for patients who are waiting on some sort of income, they're looking for employment, or they just need a little bit more time to figure out what housing works best for them. So I'll reiterate what Dr. Kwong said, a menu of options has been really beneficial. So if a patient prefers to live on the east side, may have a motorcycle, they can go here. If they need an ADA unit, they can go here. So that's been really beneficial. And then I'll also highlight again kind of what Dr. Kwong said. Our patients are also successful from the life skills and education that they're getting while in respite. They're learning how to schedule appointments, how to schedule transportation, how to manage their hypertension, how to manage their diabetes. So when they are in housing, they're able to independently support themselves. We also have our case management team that is amazing. They are supporting patients at pre-move-in, making sure they have their documentation, pay stubs, kind of anything that's necessary. They're physically there with the patient at move-in to make sure that they have everything that they need. And then they support patients post-move-in. So we've been at Family Elder Care probably about 5 to 6 months. Our case managers are still checking in on those patients to make sure that they have what they need. Next slide. And I wanted to focus just a little bit on our relationship with the National Institute of Medical Respite. You probably heard Dr. Kwong or someone say, if you've seen one medical respite, you've seen one medical respite. They are all so different because they cater to the needs of the community, and that's exactly what we want. But we really wanted to know, are we doing the right work for our community? So we engaged with the National Institute of Medical Respite Care early on, whose goal is to advance best practices of medical respite and share state of the field knowledge about medical respite care. So we met with them weekly, that turned into bi-weekly as we got going, but they were able to answer questions on, do we want to open or close facility? Is our intake process trauma informed? Are we listening to our participants and adapting our program appropriately? So you'll see on the right the meeting standards of medical respite care. I won't read all of them, but we just completed our evaluation and we scored 92% against those standards. So it was comforting to know that we were doing a good job and headed in the right direction with just a little bit of work left for us to do. And then on the left-hand side, you'll see the 4 guiding principles: trauma-informed care, disrupting the cycle of homelessness, collaborative care, and then client-centered practice. Good is the highest that you can score. So we scored good on 3 of the 4 metrics. So just wanted to highlight that partnership. We plan to continue that partnership as we go into Cameron Road, just ensuring that we continue to bring best practices into that work.
We'll end our presentation next slide with a patient story, and quite honestly, I think I had like 10 that I wanted to share, but I could only pick one. So this is Aldrich. He is 36 years old, and he was admitted after he was in the hospital for frostbite. Unfortunately, he had to have his right leg amputated, his left toes, and several fingers. And so after a 6-week hospital stay, he went to the nursing home for 2 months where he got more physical therapy. He was able to come to medical respite, continue to get wound care for his stump, finally get fitted for a prosthesis, work with our physical therapist. That's our very first physical therapist at Central Health Aubrey, who worked with him, and she's got a great layout upstairs in our respite center. He worked with our psychiatrist to work on his depression, saw our physical medicine rehab doctor, Dr. Shaw, and he successfully applied for SSI, got approved, and there he is on the right, moving into his apartment with Foundation Communities. And on the day he left, we had a little clinic send-off. This is a whole team of our clinic upstairs with him. He's just so dear to our heart. We had to take a group picture together. So this is just one example of how someone will come through respite, and our case manager, Dustin, continues to check in on him and support him, and he comes back for physical therapy. So that was our last slide. Next slide is just our summary. Really, Central Health, just so appreciative of answering the call for this need in our community. It's been, this last iteration at Clinical Education Center at the CEC has been really incredible to bring all these services to our patients. These are just some pictures that really spoke to just the care. We've got the clinical team surrounding our patient, Juan. The 2 pictures on the bottom, they're holding up their blood pressure logs and their diabetes logs. This gentleman on the bottom left, he filled up 4 books of his blood pressure and really got better control of his diabetes after his toes were amputated. And these 2 individuals, Charles and Carl, who's sitting on the bench, they just wanted me to share back to all of you that not only did respite do all of these things that we talked about, but the most important thing for them that they wanted to share is that it gave them a sense of belonging. They said that out on the streets, in the shelter, in their families, at home, outside their prior life, they never felt like they belonged. But at medical respite, because of the compassion, the care, they finally felt that sense of belonging, and that really just changed how they saw their lives. And so it's been a great honor to be part of that journey, and thank you so much for your time today.
Thank you, thank you. Thank you. Manager, so I'm going to start on the right, and we'll just kind of go around for questions or comments. Dr. Prince, thank you, Dr. Princeton.
Thank you. Thank you for the great work that you're doing.
Chair Rodriguez?
Yeah, no, thank you so much for your work. Appreciate it.
And I have to give you my thank yous too. Thank you so much. Y'all are doing fabulous, fabulous work. Thank you. Dr. Martin?
Thank you, and just kudos. And I know how difficult that work is. So I would like to ask you, I think it's wonderful y'all are tracking the bounce backs to the ER and the hospital day save, because those are real metrics we will need as a board to see the benefit. But amazing work. Thank you.
Just echoing the amazing work, and I look forward to future reports on how things are going.
Thank you. And then we have Manager Kitchen on video.
Yes, I would echo. This is excellent. I want to thank Dr. Lee. I can't see him, but I think he's there. for his leadership on this, and I want to thank the whole team. I'll be brief, Chair May. This is excellent work. So I just have two very quick questions. First off, we started this work with the aspiration that we would follow people all the way through to permanent housing and for perhaps up to a year afterwards. Now that's a huge aspiration. So I just want to check if we're still, and this might be a question for you, Dr. Lee, is that something we're still working on or working towards?
Yes, it is, and I think I see that Megan is prepared to build on that a little bit because we have some early information around how that's going.
Yes, so we.
Okay.
Yes, that is correct. So we currently have 10 patients housed at Family Elder Care through that partnership. And I want to say about 4 with some additional ones going into Camp Esperanza Community. But yes, that is the goal, to follow patients at least a year. I think even an assessment at a year on if they still need support will happen at that time, and we can continue that support. But we are building out teams now to support individuals long term.
Okay. So for example, if they end up at Arch, for example, we're still going to follow them, right? Are we still following the folks that went over to Arch?
Yes, we are. So medical respite
Okay.
still supports patients through the medical respite program at Arch. But if they go into a long-term bed, say at Marshalling Yards, and that's where the patient wants to be housed long-term, yes, our housing support program can support those patients.
Great. I'm not as concerned about like foundation communities because that's permanent, and so is Family Elder Care, and so is Community First. But these other ones, well, even like, TOOF and Arch are not. So I'm really concerned about us continuing, especially if they're going into something that's transitional. So,
Yes, so we are
Okay.
targeting transitional and shelter sites.
Okay. All right. As long as we're staying with them. And so then the last thing is just a quick, and we could talk about this more offline, but when on the data analysis, I hope you're thinking in terms of I'm not sure what the right word is, but sort of studying the before and after use for the individuals, not compared to a control group, but compared to their own usage. So I don't know if you want to speak to that now or if you want me to send you more information about that.
Yes, we have also done studies around 90 days pre, 90 days post, and we did
Okay.
present that maybe 2 years ago.
Okay.
So we've done both.
Okay, great, because that's going to give us the most data comparing to their own,
Yeah.
comparing someone's improvement to their own past.
And what
Okay.
we found there was that those individuals with the chronic diseases like heart failure, cirrhosis were the ones with the greatest impact and reduction in decreased hospital
Yeah.
days post.
That's huge. Okay, thank you.
Thank you, Ann.
If I may briefly, Chair, just Education, I wanted to thank you for your leadership in this space, preceding your time on the Central Health Board, through your time as chair. This is one of the real long-lasting contributions from your leadership as chair of the board. So thank you so much for your leadership.
Well, thank you. I just love seeing this because I was, that inception period, I was doing this way back then. And so this is huge. This is finally getting to where it needs to be. Thank you very much.
Thank you very much. All right, members, the next item on the agenda will be item 4, which is now your item 3, and that is to discuss proposed fiscal year 2027 system key performance indicators. Dr. Lee will be presenting.
Yes, thank you, Chair. Apologies, just had to congratulate the team. All right. Okay, so members, today we are bringing forward, our proposed fiscal year 2027 key performance indicators, or KPIs, for your review and feedback. In addition to the objectives and key results, or OKRs, which you all approved at our last Board of Managers meeting, KPIs are another important set of tools that help us monitor the ongoing health of the organization and assess whether we are sustaining performance in the areas that matter most. On page 26 of your backup is the memo that outlines in more detail how OKRs and KPIs work together, but serve related and distinct purposes. These OKRs represent the vital few areas where the board has directed us to drive meaningful improvement in the year ahead. They help us focus on the most important changes we have to make to advance toward our strategic direction. The KPIs, by contrast, are the core metrics we want to use to maintain performance, to manage the organization's operations, and monitor the overall health of the system. They help ensure we are staying accountable for the day-to-day and long-term performance expectations that matter most. And together, the OKRs and KPIs form a balanced scorecard. The OKRs showing where we want to improve, and the KPIs showing where we need to sustain performance across the system. We will track and report progress on both of these sets of metrics and report out on a quarterly basis throughout FY27. So as you'll see, I believe up on the screen, are we going to be showing a slide team on the screen? And if not, they should be in your memo on page 26 at the backup.
Is this what we're looking for?
Yes, that's what you're looking for.
It
So
looks like this, guys. The last,
there's
it's
a
the last page on this part of the packet.
thank you, Chair.
32.
Thank you. Page 32. Thank you, Chair. So there is, as you will see, there are 4 major sections of the KPIs aligned to our OKRs, and they are access, quality, economics, and people. The access and quality buckets align with the board's overarching objectives to create seamless patient journeys. The economics bucket aligns with the objective focused on demonstrating the value of community support. And the people bucket aligns with the objective focused on empowering and developing our team. I'll quickly walk through each of the KPIs we are proposing within each bucket, and we'll be happy to answer questions as we discuss at the end. So jumping in, within access, we will track the average lead time, which is the time between a patient's initial request for care and when they're actually seen by a provider. We report this out across every service line in our system. This is also a key OKR the board approved for FY27. So in some cases, the KPIs are also OKRs. This is one of those cases. And number 2, our Net Promoter Score, which is an OKR for this current fiscal year, but has risen to a best performance level and now is moving into the sustain category. This Net Promoter Score measures whether patients would recommend Central Health and our services to others. We will measure this metric using the results from the standard likelihood to recommend question on patient surveys and report it out quarterly. Finally, under access is the total number of encounters, i.e. the total patient visits or care interactions across our system, and report this out quarterly. Moving on to quality, we will track, and to your point, Dr. Martin, from earlier, avoidable emergency department utilization, also known as how often patients seek emergency care for conditions that could have been managed in primary care or an outpatient specialty care setting, but ended up in the ER. We'll report on this quarterly, tracking the total number and rate of ER visits that meet a set of established preventable criteria. Number 2, care gaps across several specific areas, and these are all OKR metrics as well. First, A1C, which is a measure of blood sugar control over the longer term for diabetes. We'll track the percentage of patients with diabetes whose A1C is in the out of control range. Next, hypertension. This measures blood pressure control for high blood pressure patients, extremely important for preventing heart attacks, strokes, kidney failure. We'll track the percentage of patients with hypertension whose blood control is controlled within the target range. Number 3, cancer screening rates across breast cancer, cervical cancer, and colorectal cancer, measuring the percentage of eligible patients who complete their relevant cancer screenings within the time frame recommended by their provider. I should note that there was a discussion at the last meeting around HPV vaccination, and we have learned that the current state of performance for HPV vaccination is near the very best standard already at community care, and so we did not recommend it as an OKR for this year because it's already at a top performance level. Moving on to economics, first suggestion is a prompt pay metric. This is actually very important to make sure that we are being a responsible party in all of the vendor relationships that we have. And so we'll track the percentage of claims paid on time, as well as the average number of days to payment, and report this out on a quarterly basis. The next on economics, also an OKR, a board approved this year, is non-tax revenue. We'll measure the total amount of revenue generated from sources other than property taxes, other than interest on our reserves, other than one-time purchases. So we really see the operational, the non-tax revenue coming in on a quarterly basis. Moving down to people, we will track the voluntary turnover rate. This is the percentage of team members who choose to leave the organization over a defined period of time. We'll track the total number of voluntary departures as a share of average staff size over a defined period. Report this quarterly. Then we will track compliance training completion rate. It's very important as well. The total number of team members who complete their required compliance training by the deadline divided by the total number of team members who were required to complete it. And then finally, we'll track the vacancy rate for credentialed providers at a given point in time. Very important for staying ahead of the curve and making sure we have credentialed providers to provide the services and report that out quarterly. So with that overview, we'd love to dig into your feedback and questions. Yes.
You wanna start?
Yeah, thank you. Thank you for the presentation. A few questions. Going to your measures, where's the benchmarks? So how do we know if there's been improvements of the current landscape? So the baseline data, what is it to what are we trying to achieve? So, and also nationally, are we like, what is the national benchmark to, for instance, A1C, and where's community care, for instance, or are we below, above, in between? So I think that's what's missing here is the benchmarks and where we're at, where we need to be, where we aspire to be. So I think those are really critical values that needs that we can assess and measure success. You mentioned one of my recommendations, and we approved on the including the HPV vaccination, and you said that community care is up. What is their actual rate? And how come that information was not communicated? Especially, I was the sponsor of that item, and I asked for our rate and never was provided that information. I think that is of importance, and I think if we as a board voted for something, it should be our call to make that recommendation, either to move forward or not, based on whatever information that you provide. That is just my opinion, Chair. And I think there was another item on here, I don't recall. It may have been something attributable to mental health, but I don't see it captured in these KPIs. So thank you.
Would you like to respond, please?
Yes, so thank you, Dr. Musaitif. I will look up the HPV vaccine number momentarily. I believe the commitment regarding the two follow-ups from the board was to bring feedback back for the May 27th board meeting and to have backup ready for the board by May 20th. So we are preparing to close the loop on those two issues. And apologies for not having the HPV vaccine information back to you already, but it is the Healthy People 2030 moonshot goal is 80%. The national average is 58.7%, and the COC performance level is 76.6%. So that's the current HPV vaccine data.
So, okay, if I may.
Yes, please.
Sorry. So is that one vaccine, up-to-date vaccines, and even though it's, I think what we're shooting, I think the recommendation even, it's 90%. I know the moonshot is 80%, but still, it's still, we're able to avert cancer, from our community, and knowing that those cancer and heart disease are the two causes of mortality in this community. So I would shoot for to reach the goal and higher, and I don't know if that rate is completion rate or not. So that is really my recommendation, and given that it is a critical issue in our community, and we can avert many cases. So, and it's also, it protects against 6 types of cancer. So just wanted to throw that. Thank you.
If I may respond to that, as a doctor, there's an enormous amount of pushback from patients, families, and parents because this is associated with active sexuality with people in their mind. So a lot of times you hear parents be adamantly opposed to the shot to the teenage girls and teenage boys. So I think I'm assuming that the moonshot is based on kind of long-standing metrics, but as a physician who tries to give this shot to a lot of people, and the pushback from parents is massive about this because they associate it with, well, my daughter's gonna have sex now, like if you put them on birth control for their period. So I'm just saying, but I think this is a good point.
Well,
but,
thank you. That is a well pointed. I don't know if you're all familiar. My research is actually around HPV and the way how we're moving. And yes, there has been some pushback, resistance from parents. But based on the research and the findings in the recent literature, patients who knew parents, because parents are the determinant who really decide on what they want to give their children. Once they know it's a cancer vaccine, the narrative changes, and that's the push that we are trying to move forward. Is this is a cancer preventative vaccine? Yes, you get it through sexual activity, but that's really not the recommendation that as a community that we're pushing forward. So I understand that, and I know. I've actually giving you some recent data, parents who are reluctant, who have no intention to vaccinate. Once they know that it's a cancer preventive vaccine, they're 13.5 times more likely to vaccinate their children. So I just wanted to throw that data. Thank you.
Thank you.
I do have a question.
Yes.
It's for Dr. Lee. In the terms, because I'm a doctor and into the medical weeds, what will be our measures for preventable encounters in the ER? A UTI, hypertensive crisis, suicidal ideation, and how will that be tracked? I mean, I guess what qualifies as a primary care avoidance, which we understand, but also kind of how will that data be tracked from all the different ERs that our patients use and get back to us?
Dr. Shalsh, you want to take a first stab at that?
Thanks. Dr. Martin, you're asking for the specific conditions that we'll be focusing on?
Yeah, I mean, is a UTI primary care thing, or was it 2 a.m. and they couldn't take it anymore? I mean, I'm just saying, I think we're going to sort of decide what is preventable, what was avoidable, which I think is commendable, we need to do. It's to sort of put down some metrics and then be able to track that. So that's all.
Thanks. I can tell you what we're doing and see if this meets your ask. Otherwise, we're always, happy to augment. So we're looking at, I think, avoidable and PC treatable. And we're categorizing those as far as the most frequent conditions that, for our patients that then visit the ED. And we're creating kind of patient care maps. We're archetyping kind of the patient flow and seeing why those patients are potentially falling through the cracks in care, and then augmenting that treatment and then remeasuring. So we're looking at the overall numbers, and we'll be tracking that and reporting that. And then there are subclasses under that as far as the diagnoses we can give you the most frequent diagnoses. I think one of the areas that we're still focusing on, I think, is the mental health and addiction aspect. I think we're going to touch a little bit on that as related to Sobering Center. And I think some of the areas where we can influence are, so that our patients don't necessarily end up in the ER. But all of what you're asking, I think we are working on. We're happy to report it out.
And how will that data be collected, say from St. David's, Seton Northwest?
St. David's, I think we have a little bit more of a challenge. I think we've got claims data that comes from our Ascension colleagues.
Right.
And so we're mostly focusing on that. We do have, we're still working on getting a team into St. David's, but they seem to be open to working with us.
Thank you.
Sure.
Thank you. Since we're on this side of the room, Manager Jefferson, please.
Dr. Lee, I have a question about the turnover metric or measurement. It says voluntary turnover rate, which is curious to me because I'm used to turnover being based on all separations, whether voluntary or involuntary. And I think there's good reason for that because embedded in that, you want to make sure you're tracking the effectiveness of your recruitment and selections too, which is kind of rolled into that. So I'm just wondering why the focus just on voluntary versus all separations.
I'm looking to see if Jeannie Verdon was with us today, but I think she may not be with us. So This is the recommendation from our Chief People Officer. I'll take a stab at it, but I'd want her to respond. I think the notion is that in involuntary, there was a reason why, we felt the person needed to go. Voluntary might reflect a little more the goal of engagement, where people are choosing to stay. Both are, of course, very important. And if the board preferred that we track the roll-up, we could certainly do that. These are simply recommendations. And if you have experience, Manager Jefferson, that you think the total roll-up is more relevant for the board to track, we certainly have both.
I just would ask you to check with the people officer about, for benchmarking purposes, I would think the total turnover would be more benchmarkable.
Okay, we'll definitely check on the appropriate benchmark and go with whichever one is the standard for benchmarking. Great, thank you.
Thank you, Sadora. Now I'm going to move it to this room, and then I'll go to the video. But Dr. Princeton, do you have any questions? No. Manager Valadez?
Just like to follow up with what Manager Jefferson commented on. Yes, it's a good idea to keep both, because you'd want to see if there is a trend occurring between staff and maybe their supervisors, or if there's something else going on, you want to be able to eliminate that as quickly as possible. So you need to have both voluntary and involuntary, and the reason why, okay, on that. And then with respect to the screening, you talk in terms of, for your KPIs, up to, the patient getting the screening. How about an enrollment in treatment and completion of that treatment, in order to know whether or not we're making an impact on their quality of life or life? And so to stop it just to, we want you to get screened. No, I want you to get screened. I want you to get enrolled. I want you to start taking treatments. And then I want to know whether or not, you drop out or you don't, and why. So I think that's very, very important for us as a healthcare organization, as we're trying to improve people's quality of life. Thank you.
Thank you, Manager Valdez. So we take the point about the voluntary and involuntary turnover. We'll absolutely bring that back to Jeannie Verdon. Maybe we'll track both and provide the total roll-up.
The only reason I said that is because I personally have had experience with Central Health staff.
Okay.
Who have commented to me over the past few years.
Okay, absolutely. And then in terms of the screening, you're absolutely right. We want to find the cancer, diagnose the cancer, cure the cancer, and go all the way through those steps. The first step is to find the cancer. And we know that we have opportunity to improve there. So the notion is that we're going to focus some of the effort on the front end, but we do track the full amount, and we're going to try and make sure folks are getting their endoscopies and their treatments and their appropriate tumor resections and so on. So there's a lot of data that we do track that we might not lift up in the balanced scorecard set, but if we don't get the front end right, then we don't get the opportunity.
I agree with you on the accessibility and the screening, but I think more important is the treatment and the success rate, or whether or not, if there's an issue, then I'd like for us to know as a healthcare system. Thank you.
Thank you. Thank you. Manager Kitchen, do you have any questions or comments?
Yes, thank you. One question on the, for example, on the avoidable ED visits, but it might be for other things too. Are we using, is there criteria or definitions that Medicaid uses for reporting these items? And if so, are we aligned with Medicaid's criteria and definitions?
My understanding is there's both the AHRQ, Agency for Healthcare Research Quality, definition of ambulatory sensitive conditions, but that is typically more focused on avoidable hospital admissions and not necessarily tuned for avoidable ED visits. And so there's also what's called primary care sensitive conditions, the things that should have been treated in primary care. There's a lot of overlap between these two. And so I'm not sure the team has yet lasered in on exactly how we're going to tune our ED visit metric, but we'll be using these standard sets And these are the ones that are consistently referred to and published and used as benchmarking. So I don't know if the team has a more detailed answer around exactly how we're going to ride the line between AHRQ and please.
Dr.
They
Lee,
can't
I'm
hear you.
mainly,
You
Okay.
need to move to the microphone.
okay, I'm mainly concerned that since we're moving into a Medicaid world, that we align our reporting, because Medicaid managed care, for example, requires reporting on certain things, and I'm just wanting to make sure that we are understanding how what we're tracking aligns or doesn't with what we'll have to report for Medicaid. That's really my question.
I was just going to suggest, Manager Kitchen, Sharon Always, I don't know if you can see me or not. I was just going to suggest that a lot of this is done around HEDIS and NCQA. They have real specific criteria. Certainly that's what Sendero uses, and we too are contributing our data to this initiative, so we track it that way. And that's pretty standard. And there are, the one that you were talking about, Marlo, is included in that. The HPV vaccine is a HEDIS measure as well. So I think that they're standardized throughout the industry, and I think it's a good resource. I don't specifically know that Medicaid, but a lot of times what these plans do is they rely on NCQA and HEDIS as their basis for this information. So that's what we are using, unless Alan, you think differently.
No, I think you all are spot on. I think there's an NYU algorithm that works, with HEDIS, and so we are considering that is exactly the direction that we're going.
Okay, this is a little more detail than I'm asking, really. Thank you. This is very, very helpful, but all I really want to know is, are we following what we're going to have to report for Medicaid? And if y'all need to go back and do some checking on that, that's okay. I don't have to have an answer right now. I just
We'll
wanna
check and
know if-
confirm. I believe we are, but we will confirm. Yeah.
Okay,
Very
great. The second thing was, just real quickly, I think I want to make sure I heard you right, Dr. Lee. On Manager Machado's question related to the mental health KPI, I think I heard you say that that's coming to us May 27th or May 20th?
Correct.
I'm not sure.
Yes,
Yeah,
the
heard you.
backup, I believe,
Yes.
May 20th. It should be in the
Okay.
backup and will be discussed
Yes.
at the May 27th board meeting.
Okay, great. Thank you very much. That's all I
Thank you.
have.
All right, unless we have any other more comments or questions, I'm going to move us on. I have two more.
I have one quick question,
Okay,
and
and
this
then
is
before-
more for Dr. Shalsha.
Okay, go ahead.
It's simply about, diabetes is really heart disease hiding behind sugar, and that kills more people than all cancer combined. And I'm wondering about the metric of a hemoglobin A1C less than 9. If we could maybe consider lowering that to 7.5 or 7, which is where disease stops when the A1C is, and I know that's pie in the sky with our patients sometimes, but to me, that'd be a very important thing to try and get as low as possible.
No, thank you for the information. I think we agree with you, and our teams, yes, 100% yes. And I think some of the struggles we've had as a system over time are really working with individuals who are uncontrolled, and so taking a stepwise approach, getting them into control, and then really tailoring the care to a lower A1C. So 100%.
Thank you. And I think Maram used to have a
It's
question.
really quickly, following on that, and that's why it's really important for us to have these benchmarks, and they will address all our questions around these A1C. Where do we aspire, where we're at, where we need to be? So that will be helpful for us. Second one, really quickly, in terms of the quality outcome measures for the hospital readmission, if they're within HIDIS and other quality measures, if you can select a few and then and then we'll base it on, and that's how we'll measure it, because there's multiple indicators. So if you can select based on your recommendations and your team which indicators you want to follow, and that would be something that we will measure on these KPIs. So that's really my comment. Thanks.
Thank you. Thank you. Very good. All right, folks. So we're going to now move on to item number 3, which is now our 4. But for purposes of item number 3, we're going to go into closed session, and we'll be going into closed session for the last 2 items. So one, I want to announce that the committee is convening in closed session to discuss items 3 and 5 by posted, let's see, 5 on your agenda, is posted on your agenda. And we're gonna be under, Texas Government Code, section 551.071. And this is gonna be in consultation with our attorney. So with that, we're going into close. Okay, so read it now? Oh, wait, we're going to close session to present and discuss documents related to Central Healthcare Foundation governance model. And we will also be entertaining discussion to receive and discuss the latest update on the Sobering Center. Exception to item number 5. Read that again, or read that whole thing? I announce the committee is convening in closed session to discuss item number 5 under Texas Government Code, section 551.071, consultation with attorney, and the Texas Government Code, section 551.085, governing board of certain providers of healthcare services. That's good? And the day and time today is May the 13th, and it is 4:28 p.m. And with that, we'll have our presenters move up. What?
You got a lot of them?
All right, thank you so much. We are back in opening session for the Strategic Planning Committee. It is May 13th, 2026. It is now 5:55. And we are going to go back to item number 3 on your agenda, which is present and discuss documents related to Central Health Foundation. And I would like to, if possible,
I can make a motion.
entertain a motion.
I move that, if you'll recognize me,
Yes, ma'am. I recognize Manager Valdez.
I move that the committee recommend that the board approve the proposed governance model as the framework for the foundation structure and authorize staff and council to proceed with legal formation of the foundation while continuing to work with the board on the operational governance and administrative structure of that foundation. So they will continue to come back to us until we find that final
Yes.
language model.
Do we have a second?
I second.
Okay, it's been moved by Manager Valadez and second by Dr. Brinson that we move forward with the foundation. I guess, do I have to read it again? No, that we move forward with the
I have-
motion
I
presented?
have discussion. I have discussion.
Okay. Well, I'm not there yet.
I'm sorry.
Yeah, okay. Is there a discussion?
Yes,
Manager Kitchen?
yes. Yes, the motion, I couldn't quite hear it, but we are not, I'd like to add to the motion that the staff will bring back to us the bylaw, the draft bylaws and articles of incorporation before filing them.
I think that's what we have in this motion, but if you,
Well, it doesn't say that. The motion says to create the foundation. And so what I'm saying is we're not creating the foundation. We're creating the draft documents that will be brought back to us before creating the foundation.
well, what we're saying is while continuing to work with the board with the operational governance and administrative structure of the foundation.
What is it? Can you read the motion to me again?
Sure, let
please?
me read it, maybe you didn't hear it very well. The motion reads, I move that the committee recommend that the board approve the proposed governance model as the framework for the foundation structure and authorize staff and council to proceed with legal formation of the foundation while continuing to work with the board on the operational, governance, and administrative structure of the foundation. If you'd like, we can
Okay,
bring-
here's the problem. Here's the problem. We're in my mind, we're authorizing the staff to proceed with legal formation of the entity. That's the part that I'm suggesting that we are not doing. We're not asking them, once they file the bylaws and the articles, they have legally formed the entity. I want to be clear that we're not asking them by this motion to go ahead and create the legal formation, because that has to come back to us. So I think we just need a word.
I have
See,
a
we-
question. Madam
Yeah,
Chair?
Okay, hold on. Just a minute. Let me recognize Cynthia, and then we'll continue with this conversation and discussion. Cynthia?
Can we just add or put comma prior to final board approval of those documents, of said documents?
Would you like to repeat that again?
Yes, I said comma, prior to Board of Managers' approval of said documents. Said documents is all documents. We're not going to approve anything until we have a final form, if I'm
Yeah.
correct, and then we vote. Is that not what I'm understanding, Hal?
Where's Hal? Hal, would you come, is Hal here, or Virginia?
No.
Okay.
Virginia
Would you
is.
clarify this motion since y'all were the ones that were drafting it?
So we are recommending that we go ahead and file the application for entity formation. That does not mean we will submit the bylaws or the articles of incorporation. We will continue to work on those and meet with you all individually before the June strategic planning committee to review those, similar to what we did here, have the feedback, integrate it, and then come back to you for any discussion. But what the motion was intended to capture was to be able to go ahead and file for the formation without, that's only the first step, because that piece can happen in tandem while we work on the other operational pieces of the
Well, then I have a
bylaws and the
question.
corporations. Yep.
Could I have a question? My understanding, and Hal is there, he can correct me if I'm misunderstanding this. Once you apply, when you apply, you have to file your articles of incorporation. That's what the application is. It's not a two-step process. Once you've done that, you've created the entity. Am I correct, or am I
You are
got that
correct.
wrong, Hal?
And
Yeah.
I would
So
like
you're
to be
creating-
recognized to
you're-
make a different motion.
Yes,
Okay.
You're correct.
okay. All right. Since I have a motion on the table, and I'm gonna need some, Robert's rules here. Yeah, so, okay, I have a motion on the table, and Manager Kitchen proposed to amend it, and we haven't voted on that. Can I table that to pick up another motion and see what the other motion is, or how does that work?
Could I suggest that I read what I would like to do, and then Manager Valadez
I
can
can
decide whether to
withdraw.
withdraw her motion?
Yes.
Okay,
What I would like to do is move for adoption of the language that's on page 23 of the packet, which is what I thought we were doing, and I'm fully supportive of. So the language that is there is what I would like to substitute as the motion.
Can you read that language, please?
So that language is, I move that the Strategic Planning Committee approve the proposed, I would say the proposed Model 3, I think it was, to the governance, as the governance model for continued development, and direct staff and council to finalize the foundation formation documents for a charitable foundation to support Central Health's philanthropic fundraising efforts, including drafting the bylaws for the committee's review and approval, and upon such approval, to forward a recommendation to the board for consideration and action. So
That works.
I can say it more simply. I move that the Strategic Planning Committee approve the recommended governance model, which was number 3, as a framework, and to authorize staff and council to prepare the formation documents for board approval.
do you accept?
That gets it. That gets what I was concerned about.
Yes, I'll withdraw the motion, and Cynthia, who is my second,
I agree to withdraw that motion.
So do we have a second now to
I'll second.
Sador's? Okay.
I'll
Moran
second
will second
Sador's.
Sador's motion, okay. Although, any more discussion? All those in favor, please signify by saying aye. Aye. Any
Aye.
against? None? So be it. Thank you, it passes, motion passes. Thank you, thank you.
didn't realize
Thank you.
that this motion was a little bit different.
Yeah, well. That could kill you.
Do you need a motion for adjournment now? Do we need a motion for adjournment now? If that is acceptable, I move that we adjourn.
Yeah, yes, and your last.
Oh, unless you're going to tell us when our next committee meeting is. That's the last thing.
Sorry, manager. Your next committee meeting is tentatively scheduled for Wednesday, June the 10th, 3:30, here at Central Health offices. I will now take a motion to adjourn. Thank you.
So moved.
Motion, I accept it, and it's
Second.
second. And meeting's adjourned. Thank you.
All in favor?
Aye.
Do we have to pass a motion to adjourn?
Yes.
All those in favor, please signify by saying aye.
Aye.
Any nays? None. Thank you. Okay.
Too bad.
Managers, there's food next door, so we'll try to start at 6:15 in 10 minutes if possible.
Lisa, get y'all's act together. Come on.
me go see
Go
it.
see what you got.
Yeah,
Get
because.
this done anyway. My daughter, Cynthia. Yes, but look at what else she did. I think that's hilarious. Newer version of Rodos.
That sounds really good.
Because they've been telling us we're gonna be here till 10 or 11.
I wasn't expecting that. I thought we'd be done at 6.
They told us last week.
Because I
Maybe it
didn't
was
want to
after
hear
the
it.
meeting was over.
Yeah,
Maybe it was after the meeting was over they said that.
or I didn't want to hear it.
Yeah, yeah.
Because I have to go, well, I'm going to go to the jail,
Yeah.
but then I have to go to Denton in the morning. Denton. And go to,
It's gonna be about 4.5 hours.
yeah, and then I have to speak, and
Yeah.
then I've got to get up really early and come back so I can go to work. So I'm like, oh, I was so thinking I'll just go home and I'll pack. No.
Well, you can walk out the door, we'll still have a quorum.
Yeah, we'll see how tired we get. Or maybe they'll just
You're gonna
hurry it
have
up.
to drive tomorrow, unless somebody's driving you.
No.
Which one did you get?
I got the steak.
Oh, okay.
The reason why is because
Protein.
I have the jeans, both of them.
Go over and speak to both you two ladies.
Oh, good to see you. I'm terrible. And I haven't gotten back with you.
And
So crazy.
as you come up here, I continue to think to myself, oh my God, we are so lucky we have Sharon.
I know,
I mean, really,
really.
we have
I feel like
elevated.
sometimes I need to shut my mouth.
No, you don't.
No.
Because what you're doing is continuing to prove, yeah, you made the right decision.
Well, you know everything.
That's right,
Well, that's
that's
not
right.
right, but you're right. I mean, there's some of that stuff is, oh, I thought those things that we're looking at them from NCQA. And
Yes,
stuff,
yes,
and
yes.
sometimes those are pretty standard. Most of the stuff around Medicaid is more like, more hospital-based, it's more like, place to stay, days, and that kind of stuff, not directly on.
Good catch on her part.
So we don't need to start paying attention.
No, but you have an understanding of where that protection is in place in the other regs. And individuals, we may not know that, and you will know that
Good afternoon, members. Today is May 13, 2026 at 6:20 p.m. As a quorum of the committees in attendance, I'd like to call to order the meeting of the Central Health Executive Committee. And as a reminder, some of our committee members may also be participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have legally compliant meetings at all times. I'd also like to announce that in order to make it more accessible to community members, we previously held public communications for the Strategic Planning Committee and Executive Committee meetings at 3:30 p.m. And unless there's a member of the public that wishes to comment on a specific item on this agenda, now we'll move to our agenda. We have no one from the public here, so we're gonna move to our committee agenda. Our first item is to approval of the minutes of Central Health Executive Committee on April 8th, 2026 meeting. And is there a motion to approve those?
I move to approve the minutes from April 8th, 2026 meeting.
Thank you. Is there a second? Having a,
Oh, you have to second.
oh,
You have to stick it? I thought it had to be from the committee. Second?
from the committee. Okay, so Manager Musaidov moves and Manager May seconds the motion to approve the minutes. All those in favor? The motion passes unanimously. Members, we're gonna move on to item number 2. Review and discuss a report from the board chair, including board meeting mechanics and government updates and tentative schedules. So I have a couple of quick updates. One is, as you all know, and thank you very much for attending the second governance retreat on May 2nd. And as you know, we're incorporating the board work plan, and we'll be sending that out to you to make sure that we're both held accountable and it's transparent about what the board is working on as follow-up from the retreat. The second item was to remind committee chairs that packets are to be distributed 7 days in advance of the meeting date. And this is one of the action items on our work plan. Dr. Lee, thank you. Around the Board of Managers meeting, we've been consistent around providing the material and posting 7 days before, along with having the material 7 days in advance. And I think we wanted to now make that the same requirement around our committees. And then lastly, around schedules, a couple of things, members. This week on Thursday, May 14th, we have the third quarterly update to the Travis County Commissioners Court at 1:30 p.m. sharp. Also on Thursday, May 14th, we have the community conversation in Precinct 4 at the Metropolis Recreation and Community Center at 5:30 p.m. with County Commissioner Margaret Gomez. That is tomorrow. And then on Saturday, we have the Colony Park Health and Wellness Center groundbreaking ceremony and celebration at 10 o'clock. And if you can make it, that would be great. In addition, there's a few special called meetings we posted for Tuesday, May 19th between 4 and 6 p.m. If you would let staff know, we're trying to figure out if we can have quorum for that special called meeting. And then if there are questions, there's also questions about which second date to use. And if you would respond to the emails regarding Thursday, May 21st, or Friday, May 22nd, or Tuesday, May 26th for these additional special called meetings.
Chair,
Yes, that's all, that's my update. Manager Musaidov, and then,
I just have a comment
Uh-huh.
for Saturday. Has our Mr. Shannon Jones been invited?
I believe is speaking at the event.
Oh, okay, just wanted to make sure. Thank you.
Members, any questions?
No.
And if
I have a
not,
question.
oh, sure, Manager Getchin.
Okay, I think this is part of this item, but there was some, in backup, there was, if I've got the wrong item, just tell me, but in backup, there was, a listing of, items for upcoming board meetings. Is that for this item?
Yeah, it's under tentative schedules.
Yeah.
Yes.
It's missing something, it's missing an item, an action item for the May 27th meeting. And so I wanted to get on the record that we need to add for the May 27th meeting a vote on a recommendation from the liaison committee to approve motion number 2.
Got it. We'll make sure. Did you get that, Bella? Yeah, she got it.
Thank you.
Thank you, managers. Any other questions? Thank you. If not, we're gonna move to item number 3, receive an update on fiscal year 2026 system objectives and key results performance from Dr. Lee. And we've got that under the 4 criteria that create simplified patient care journeys, build a comprehensive equitable health system, demonstrate the value of community support, and empower and develop our team. Dr. Lee?
Thank you, Chair and members. And I believe we are pulling up a slide as well, if you'd refer to on a screen. I want to spend a few minutes walking through our Q2 progress against the system-wide fiscal year FY26 OKRs, which were developed pursuant to the board's direction last year. We started with a clear goal to cascade our OKRs through our leadership structure and create shared accountability across the system and team. Today, we have over 90 directors actively participating in the OKR templates, exceeding our target of 81. And that means more leaders across Central Health, Community Care, and Sendero are working from the same playbook, tracking the same priorities, and aligning their teams around the Central Health Board's vision. This shows that the OKR framework is becoming a management system for how we drive transformation, measure progress, and hold ourselves accountable across the system. And we are making meaningful progress across all 4 objectives. So with that, let's dive into the OKRs. First objective, to create simplified, seamless patient care journeys. We are seeing strong progress in our work to make care easier to access and easier to navigate. One of the clearest examples is reducing appointment wait times. At the end of Q1, the average wait time across medical and dental care was 34 days. By the end of Q2, that had improved to 21 days. That is a significant move in the right direction and reflects the focused work of our teams, including weekend and after-hours clinics, to help reduce backlogs and expand access. We're also making progress to reduce avoidable readmissions and emergency department utilization. Our data review is improving, and our teams are working more intentionally across the care journey to identify where patients need support before they end up back in the hospital or the emergency department. On resource utilization, we are also beginning to build a stronger planning framework. About 56% of Central Health specialty providers were at or below the 75% utilization threshold in March, and we now have service line right-size estimates in place to guide staffing and capacity planning. That gives us a much clearer view of where we need to expand capacity and how we can use existing resources more effectively. Second objective, build a comprehensive, equitable healthcare system. Some major highlights in our progress against our key results. Patient experience is a clear bright spot. We exceeded our patient net promoter score target, reaching 80 against a goal of 76. 80 for a federally qualified health center is an extremely good net promoter score. We also improved complaint resolution time beyond target, bringing it down to 13.4 days. And those results matter because they show that patients are not only getting care, they are increasingly experiencing that care as responsive, respectful, and supportive. We are also making progress in coverage. MAP and MAP basic enrollment increased by 3.5%. Sendero enrollment is trending well above goal, and the number of incomplete applications has dropped from 36% down to 29%. On quality care gaps, we are seeing signs of progress as well. Prenatal care entry rates and A1C rates are trending ahead of where they were last year. Our continuous glucose monitor pilot in particular is showing excellent results. We now need to scale this work up across our broad population, in which we have many patients with diabetes who could benefit from these CGMs. Colorectal cancer screening remains an area of focus, but we are currently trending modestly above last year's performance in this area. Third objective, demonstrate the value of community support. Some major highlights in our progress against our key results. We are seeing strong performance on favorability and sentiment. The combined positive and neutral sentiment remains above 90%. There have been multiple presentations, community events, positive media coverage, opening of Hancock, government affairs work, and so on, all of which have helped reinforce Central Health's value to the community. We are also making real progress on reducing system duplication and strengthening integration. We completed the full set of Phase 1 integration areas, namely healthcare for the homeless, EPIC, pharmacy services, addiction medicine, and eligibility, all substantial areas of our work. We are now advancing Phase 2 areas, including provider credentialing, ambulatory specialty care, transportation, and revenue cycle alignment. This is exactly the kind of behind-the-scenes work that helps us operate more like one team, reduce duplication, and become better stewards of taxpayer dollars. On non-tax revenue, we are seeing strong momentum. Third-party payer revenue exceeded goal this quarter, reaching $4.2 million against a $3 million target. That is a very positive sign as we continue working to diversify revenue and maximize the resources available to support care for Travis County residents. The final goal to empower and develop our team. Some major highlights here. As I mentioned earlier, one of the most important accomplishments this quarter is the way OKRs have been cascaded through the organization. We now have 90 directors and higher level leaders participating in OKRs over our target of 81. That helps us create shared accountability, make sure leaders across the system are aligned and working to the same priorities. We have also integrated OKR competencies into our Guide with Love leadership curriculum, helping to connect our culture work directly to the advances on measurable progress. On team member engagement, about 77% of departmental action plans resulting from our Big Listen employee engagement survey are now underway, which shows importantly that leaders are receiving, synthesizing, and now acting on the feedback we received from staff. And on belonging, we've launched 2 of our 3 communities of belonging with strong participation and very positive feedback from recent events. This work matters because system transformation depends on our people feeling connected, supported, and clear about the role they play in our mission. In reflecting on all of these, a few major bright spots stand out that I want to lift up. First, we are seeing real adoption of the OKR framework across the system. More leaders are using it, more teams are aligning their work to it, and that foundation will continue to get stronger over time. Second, our integration work is moving forward in meaningful ways. This is complex, in some cases slower than expected, but we are making progress in the right places, and most importantly, doing it in a way that honors the nuances and the dialogue between different teams and leaders and supports our long-term success. And finally, this quarter we saw some really tangible wins and results that are exceeding goals. Stronger access performance in several service lines, shorter wait times for medical and dental, improved patient experience scores, continued enrollment growth, better non-tax revenue, and more. These successes are important signals that this work is producing results, even as we continue to work through barriers. Thank you for your leadership, and I'm happy to take any questions.
Members, any questions? Manager Wallace?
I just have a quick one. I'd like to know, again, Dr. Lee, how with the numbers, current map, and then how did they increase? Map basic numbers.
I see John Morgan. We have a slide that we're presenting tomorrow to the Travis County Commissioners Court. I will do my best to remember. I believe we are up 7,000 members on MAP. And let me not, we're going to get that slide and we will answer the question precisely in just a moment.
That.
Yeah.
That's it. Thank you. Go ahead.
go. Okay, so this is the slide we'll present tomorrow to the Travis County Commissioners Court. In 2025, it's 62,587 patients on MAP, up from 58,646 patients in 2024. But if you compare to 2021, that was 47,000 at that point. So a 34% growth in MAP since 2021 to 2025. So those are the MAP numbers.
Will you all be providing us a copy of the presentation to the Commissioners Court? Thank you.
Yeah.
Members, members, any other questions? If not, we're gonna move on to item number 5. And then just members, if you just notice, I skipped number 4. We're gonna pause that one. That one is about policies dealing with general procurement and delegation of purchasing duties to purchasing authority in certain officers. And the reason we're pausing it is, as you know, in our retreat, we discussed having our outside counsel provide some edits and suggestions that we had made, and so we're going to be having them review it, put some edits, and then having us come back and look at it. And it has to do with the whole delegation of purchasing duties in particular, but also some general procurement issues as well. And so we're gonna allow them to have time to do that. So I'm gonna move to item number 5. Receive and discuss a presentation from the Central Health Chief Compliance Officer regarding the process and timing for board review and approval of district policies. And welcome to Kim.
All right, good evening, everyone. So thank you for having me. Today I'm bringing forward a proposed board policy framework to create a clear governance structure around basically our policy oversight, our approval authority, and how we operate internally around how we manage our policies and procedures. And this actually is one of the initiatives that I was asked to bring back when I initially started. I was asked to review our current list of policies and procedures and then to provide a proposed framework on how we could review those and have those approved and what our governance structure should look like. So as we've continued reviewing our governance structure, it really became clear that our current policy inventory includes a broad mix of documents, some that are appropriately categorized as board governance policies. We also have those that are considered operational or management policies, and then we have some that are detailed departmental procedures, which those are dubbed as standard operating procedures. So this framework that is outlined in an executive summary on page 90 really is intended to create a clearer and more sustainable structure that aligns with policy ownership. And then it also allows the internal management team to approve policies under the board's delegated authority. So this approach aligns with government oversight. It actually helps the board focus more on strategic, regulatory, and high-risk matters. And later you'll see in the inventory how much volume we have to get through if we approve our policies. So under this core framework that's proposed, we're asking that we align our policies in 3 distinct categories. First will be those that are considered board policies. Those will be the policies that the board will govern. They typically fall under organizational oversight, strategic authority, fiduciary responsibility, matters that the board reserves under statute, under our bylaws, and then any governance expectations. There are some policies that we have that are intended to be approved based on regulatory requirements. So, for example, governance, compliance policies, those around financial oversight, delegation of authority, and then any other executive accountability that we feel the board should be reviewing and approving. The second set would be considered administrative directives. Those are truly your policies that the board has delegated to management to develop and create within the departmental structure. Those will go through our current management policy approval process today. Those are, and I provided some examples, those may be vendor management processes, things that are intended to be like day-to-day oversight. And then some are standard, some are contracting routing. Anything that has not been delegated by the board as approval authority may fall within that category. And then the last is our standard operating policies and procedures. Those are the ones that are detailed workflows. They're used by the departmental areas. They're operational processes. So this framework does not intend to take over the board's authority. It's really just reducing the oversight and the burdensome of reviewing every single policy that we have. And it also allows us to clarify operational and governance authority and where we want strategic priorities to be. And it'll in fact strengthen how we focus on policies going forward. And this framework is intended to be included, if we go forward with this, intended to be included in our policy and procedure on policies. So as part of this work, I was asked to provide a complete inventory of our current policies. So that is in your packet beginning on page 91. And this inventory confirms that we have a significant volume. I've actually taken it and categorized it by department. I've included the classification. You'll see where we have some that are considered policies, some that are SOPs, some that are manuals, departmental templates. And then based on this proposed structure, I have taken the liberty of classifying some as board approval, or those that we would consider management approved within the department, and then those that are considered SOPs. So currently today we have 492 active policies. That includes all of the artifacts that you see in the inventory. 202 are considered truly policies. So those are the ones that will be today presented to the board for review and approval. If we decide to break it out and follow this proposed structure, it'll allow us to review about 27 policies, I believe. And again, this is just my first take on what may fall into the board approval process. This is not concrete. I'm looking for the board's direction and approval on that. So this is just sharing you what may fall into the board approval process based on my review. So as next step in this process, it will be a phased approach, right? Because we still need to get through how we want the framework to be structured, meaning how we want to bring policies before the board, what committee. And then also we need confirmation on those that we are going to classify as policies versus SOPs and management directives. And then we want to prioritize them. So once we get past the framework and if we're going to move forward with this structure, the idea is that I will work with the board on prioritizing those for board review and approval. And then we can also agree on when we want to have those approved by, if we want them approved by fiscal year beginning 27 or the end of fiscal year 26. And then also we'll prepare a schedule for that timeline. And then the last is that we'll I'll work with the operational areas on those that are considered documental and departmental policies and procedures, and bring a proposed structure for the board to have oversight in that process. And one idea is that we bring quarterly a list of those policies that have been approved under management's authority, and then the board could request to see those at any time, but at least you'll be able to see the activity that has occurred continuously with the departments. So it gives you some oversight into the process and what's been approved. So I'll stop there and ask if there are any questions.
Nakia, thank you for that presentation. Members, this is an information item, but we do want to make sure that you have an opportunity to ask questions. I will say that this is part of our duty of loyalty, duty of care, fiduciary duty in reviewing policies. And policies is where we lead the organization. And so it's important to have board engagement and any feedback to Nakia about any policies that are missing or any of the other issues that she presented in the framework. So we'll have time to get feedback in addition to tonight, but we wanted to make sure that you saw this framework and you saw what the line of sight would be for any administrative operating procedures to come back to the board, and just to make sure that we answer questions and there is clarity around accountability, transparency, and responsibility, either on the administration side or on the board policy side. Manager Musaitis.
Thank you, Nakia. I really want to recognize the amount of work that you've been doing in this short period of time. Thanks for all your hard work and your team's work. A couple of things. If possible in the future, in terms when it comes to approval authority, because there's so many, if you can filter it what is under board authority, if you can group it, it'll be much easier for us to decipher like what is under our authority. And for something what has stood out to me, like the standing order authority, it says under management authority. So do you differentiate clinical management than operational management?
So those that fall under standing authority are all of our policies that fall under the scope of the healthcare delivery area, and those policies go before the medical executive.
I'm sorry, Nakia, I can't hear you.
Oh,
I'm so
sorry, she
sorry.
didn't have her light on, sorry.
My apologies,
Go ahead.
I'll go back. So the policies that you see that say standing orders, those are all the policies that fall under the healthcare delivery area, and those are sent to our medical executive board for review and approval.
Well, I understand, but if you can distinguish the management authority, if it's clinical versus non-clinical,
Okay.
it will be helpful because, clinical, it goes through that committee for approval. I just wanted, just for clarity
Oh,
on
perfect,
that.
yes.
And my other question too, what does MEB stand for?
Medical executive board.
Okay, thank you, appreciate it, thanks.
No, and now just to reiterate that any acronyms, spell them out. And I think as you've alluded to, a lot of these procedures and some of the administrative policies, as long as there is a line of sight back to what authority is being delegated by either by the board or the board to the medical executive board, just to make sure that we all are seeing the line of sight to policy and the delegation of that authority. Members, any other questions? Manager Jefferson? And
I
then
just want to
Manager
say that
Kitchen.
the overall framework looks reasonable and appropriate to me. I'll probably want to just look a little bit more carefully at the ones that are pegged for board and maybe management, just to make sure, but I like this format.
Yeah, it is an opportunity for us to question whether something is a management procedure or whether it's policy and why. Because we're doing it, this is the first time that we're
Yes.
doing it, so, and as we move from payer to payer, somewhat of a provider to a payer provider, and then whatever the next evolution, this is good foundational
Just one
work.
last
Yes, Manager.
Could it be possible to add the date of that, policy? Because to know if it's a new, policy, and
Yes.
also, do we have also, in our, when we should review policies, do we have a time frame? Like-
Yes,
Yes,
we've
it's in
asked
the
about that, whether statutorily there's a requirement to review the policy or whether we are setting up a timeline for policy and then phasing in that approach. And then also where they're not able to document a particular policy and when it was created, then we're creating a new policy and incorporating new updates to it
Okay, thank
as an
you.
approach.
I think just the date of the policy would be helpful, thank you.
And that's also in the header of the policies as well, but I see what you're saying around this particular list. But as you recall, the standard policy heading now will have the date of approval, when the board updated it, and all of the kind of information, yeah.
Yeah, we can pull it in the system. One of the things I also want to add that may be helpful for your review, outside of today, I created a very detailed document that accompanies this summary. Is very high level. So there's another document that I review with chair and vice chair that actually has acronyms. It has definitions in the back. So I'll float that around so you can see that.
Yeah.
It'll help with your review of this. I just didn't include it today because it was kind of lengthy, but it'll help you with the review, and it may address some of the questions around acronyms. I also added a section in that document that includes the items that we'll include in the new policy. So it kind of defines like the board's authority. So I'll send that around as well.
Thank you, sure,
I
Manager.
just want to say that having done these kind of things before, I know how arduous it can be. So I am hoping that you're going to be able, when you do this review, the 500 and something is going to be collapsed, and you'll find inefficiencies and redundancies, and that'll be collapsed. And the same thing, ultimately, whatever the board feels that it's within its purview, that we'll, take a look at those, and maybe those can be even collapsed, and we might find some efficiencies there too. So I guess I would say is that I'd rather you start with a big list and then a process, and then in that process, figure out how to make this much more approachable, because nobody's looking at 500 and something policies, right?
Yes, and with that said too, Manager Jefferson, we've also had a discussion about the IT help here around software. Currently, Central Health in the enterprise, kind of the partners of CUC and Sendero, they have 3 different software systems for policies. So I think there's an opportunity there as well to become more efficient. Manager Velez?
I'm sorry, I thought we were all on Epics.
Epic is a medical record system.
Epic, okay.
There's software systems that manage policies
Okay.
to ensure also, like, for example, conflict of interest, and there's some add-ons on there where you can do online, instead of every year printing out pieces of paper electronically asking you to fill out annual conflicts of interest or duality
right.
of conflict forms. And there's a way to document that so that when Nakia gets a knock on her door from CMS, she's able to quickly document that everyone has done their conflict
Due
of
diligence,
interest,
yeah.
due diligence, and where all the policies are. Because one of the criteria is that, one of the requirements is that the policies be accessible, and we can show that through the software system. And the board also will have access to them. So that way you can 24/7 at 11 p.m. or 3 a.m. in the morning, you can get up and
Go
log
look.
on and read the policies that you want to read. In case
Yeah,
you can't sleep,
that's right.
it's a good, yes, exactly. Manager Kitchen, I know you had your hand up.
I just
Oh, sorry.
wanted clarification, Nakia, you're gonna be sending us the larger, the detailed, and then separating out board management. Okay.
I'll attach the spreadsheet to make it a little more friendlier, but you'll get the spreadsheet, and then in the spreadsheet, I have a couple of tabs that'll kind of help you see like the volume.
Okay.
You'll see like a graph that have like a total that we have today, those that we've aligned as, board policies.
Hi, Nakia. I can't hear you.
And how
I'm
long it
sorry.
will take you to review them.
I appreciate
So I'll send that to you guys, but I need to add the items that you asked me to add
Okay,
today.
and
I'll get it
also
out.
the compliance, the grievance process?
Yes.
If it's separate, different from for the board as it is for employees?
You mean the actual policy?
Yes,
Oh, yes, it's in here under the compliance policies.
okay.
Yeah.
And if you need a copy of that, they can print it out for you, because I think the question you're asking is probably the answer to your question is in the policy, so.
Oh, okay, I'm following you now.
Yeah,
We can
that's
get
what she
you a
was
copy of the
asking.
policy, yes.
I'm gonna turn over to Manager Kitchen. You have a
Yeah,
question?
just very quickly.
Yeah.
So, did I hear you say that all these items that are policies, I agree with this framework, and thank you for all the work putting this together. This is great. So all the ones that end up in the policy bucket are the ones that we are systematically going through and over time reviewing and approving, right?
Yes, yes, correct.
All of them, not just, I thought I heard you say that there were 202 of them, but that we were only going to go over 90 of them or something like
So
that?
so in the inventory today, there are a total of 492 artifacts, right, that are combined.
Yeah.
When you filter it out and just look at those that are dubbed as policies, we have 202. And then
Okay.
if we filter the list by those that we are going to agree that are going to be board approved policies for this first go round, I think I have about 27 of those. So we will bucket
but,
them out as board
That's it.
approved, and those are the ones
But
we will
all-
focus on.
But all
We're gonna
policies-
review all of them, but Nakia is saying that
Yeah.
the first bucket, the first tranche, the first phase is these 27 policies.
Yes.
Right.
Okay, which 27?
So in
Do we
the
have a,
in the column under approval authority, you'll see those that are highlighted as board approval, and then you'll see some that are management approval. So we'll filter the list out, and we'll start working on prioritizing those under the board approval bucket and start routing those to the board for approval.
Okay, so the reason I'm asking, Chair, is that I guess I'm not understanding. I know it's going to take priority, so that's fine.
Yeah.
But I thought that all policies would be reviewed, have to be approved by the board.
Yes, they do.
So-
For example, what I think Nakia is saying is that they are doing a lot of work to discern which
Yeah,
ones are policy and which ones are not. And those that are policy, we're gonna take in a phased approach. Those that are not policies, they will also make sure that we know what those are. And then with user ID and password, you can go in and check, because one of the things that would be great for, again, anyone at 3 a.m. in the morning or 11 p.m. at night, if you want to go in and check those, the ones that they've discerned are management, because there's authority from another policy and the authority has been delegated to them, then we can ask questions about that and pull those out and say, well, no, actually, let's have a discussion because I think this one is a policy. And I think you'll start seeing with the 27 that these are real high level priority items. And just imagine the first one's HR, discrimination, retaliation policies, all those kinds of compensation benefits pieces. Those are all traditionally the first phases. I'm sure there's others around risk management as well. But I think if there's some that you all have questions on or want to look at, dive deeper, I think Nakia is really open to making sure that we're listening to the board about what's important and what's a priority. Oh, that's
I just want
helpful.
to be, yeah, but I'm sorry, maybe it's use of the term. So I still want to make sure that we are getting to all policies. So when you say 202, so are there 202 that have been identified that the board at some point in the future will need to approve? Is that what we're saying?
The 202 documents are all the ones that are considered policies. And if the
Okay.
board does not
Yes.
delegate those to the management to approve in the department, those would then fall to the board for approval.
But at this point, they remain on our list
Yes.
to get to, right?
Yes.
Okay, and so on this list that's in front of us, the 202 are all, they're all under that third column that says policy, right?
Yes.
Okay.
Classification, yes.
Okay, so that's where I can see. And the 27, where do I see, which are the 27?
So when we filter under approval authority, we're gonna start with those that say board approval, meaning board approval is required for that policy.
Well,
So
board
where you,
approval is
that's the
required for all policies.
right, but this is the recommendation of administration that these are the first 27 to approve.
Yeah.
Yeah,
Well,
that's all
I'm-
that means.
All right, could you I mean, in the future, could you reword that and just say priority or something? Because it makes it, I'm sorry, I don't mean to be dense, but it makes it sound like those are the only ones the board's gonna approve. And that's why I wanted to clarify.
Yeah, I think
So-
it may be helpful when you see the extended version of the framework, because it kind of lays out the authority that the board is going to delegate to management, and how we're going to take that authority and develop policies under the board's direction. So it's not saying that the board doesn't have the authority to review and approve all policies. It's saying that the board is going to delegate a subset of policies to management to approve under their authority.
Okay, that's where I'm
Does that
getting
make
confused.
sense?
Okay.
Yes, but I would, Chair, the difficulty is the use of the term. So, and I'll let it go, we can decide it later, but I thought we were using the term policy for, everything we call a policy is the board to approve.
Yes.
Not to delegate to management to approve.
Yeah.
So if it's management's approval, it's not a policy. It falls into, it's either administrative directive or standard operating procedure. So I think I'd like to, I don't think our nomenclature is following that at the
Yeah.
moment.
That,
You see what I mean?
Yeah, that's helpful feedback. I think once Nakia sends the more detailed framework memo, if you still don't have that clarity, we can come back and clarify that.
Okay.
Yeah, it's not clarified on this column, because
Yeah.
these columns have things listed as policy and then they say MEB, but
Yeah.
nothing that's listed as a policy should say MEB.
Yeah, and then those are pulled from a base, from your policy software system. And so they can pull out other data as well. And MEB means that their policy, we, the board, statutorily, the medical executive board of Central Health has been delegated certain authority for policies. And so that's why MEB policy and board policy,
Yes.
are different.
Oh, I'm sorry.
Yeah.
I was
Yeah.
thinking MEB was the management.
No, those are the
Management.
ones
No,
that are.
no, medical executive board. Yeah, that's a
But
policy
there
level.
are, yeah, there are some on here that are marked policy and then it says management approval.
Yeah,
That's what's not jiving with our nomenclature. Nothing should say policy and then management approval.
we hear that and we will get clarity around that. And Manager
Okay.
Valadez had a question. I know Dr. Lee also had a comment.
I think what happened, Nakia, is when you're speaking, it sounds like what you're saying is what Ann is concerned with, and that is that there are policies that have been listed that are going to be approved by administration or by the administrator, that we will be provided, and I can understand, because I was trying to re-listen to what you were saying.
Yeah.
And what I wanted to hear is say, and we will identify those policies that we are going to bring to you as a board to, accept as being your under board approval, or they will be directed to. I think that I may have been hearing it in reverse. So that it's, the words that you were using didn't seem to jive with what I know you were meaning.
Yeah.
And that's all. That's
Thank you.
Sarah.
Thank you. This is good feedback, Dr. Lee.
Yes.
Thank you, Chair. And Manager Kitchen, you used the term administrative directive, and that's the nature of my comment. We hear loud and clear that at Central Health, policies signify board approval, and that the preference is to use the term administrative directive for principal frameworks that are then used to develop standard operating procedures. Part of the rub is that external compliance structures like the Joint Commission or Mazars are expecting to see the term policy as the framework for SOPs. And in fact, we were cited by Mazars that we didn't have enough operational policies, so we actually turned some things into operational policies. So we actually, I forget the name of the specific policy, but Nakia has a policy that defines operational policy at Central Health shall be known as administrative directives. So we can be clear on our terminology and still be compliant with external review. And I think we're just getting hung up. So
Definitions.
the recommendation I think that Nakia is making is that, my math's not good here, but maybe 175 of the 202 things flagged as policies are recommended as administrative directives, and 27 are recommended as board-approved policies. Am I reflecting your intent, Nakia? So apologies for our lag, but we hear the board loud and clear. We're trying to nuance how others are expecting to see our documents titled as well from the outside.
That's correct.
Okay, thank you for the clarification. So I understand as a next step, if we have feedback on any of these policies that we would like to see because we think they might be board
Yes.
policies, we should just send an email, right?
Yes.
Can I just
Yep,
make a
thank you.
comment
Manager
really quick?
Valadez. Yep.
I think I understand where Manager Kitchen is coming from, but we need to be very cognizant of the environment and what is the common language. In institutions and organizations, they all use policies, so it's upon us to distinguish what's our authority, what's not, and we need to really align our language accordingly. So just a comment.
Yeah, thank you. I think, Manager, if there's no other questions or comments, I'd encourage you to kind of review that, and then Nakia is gonna send the expanded framework. And then I'm gonna move us to item number 6, review, discuss, and take appropriate action on an annual compliance risk assessments as recommended by the Chief Compliance Officer. And Nakia, this one is an item for action.
Correct.
Yep.
So let me switch gears here. I'm excited to present this item too. So,
The microphone, it might help also.
okay, I'm moving to page 100 in the packet. So I'm excited to present our baseline compliance risk assessment summary. So the purpose of this assessment was really to establish a structured way for myself to come in and look at risks that we've identified in the organization and then identify where areas where governance, controls, oversight, and continuous monitoring and auditing is needed. So this assessment actually is a proactive assessment that compliance officers conduct annually. So some of you may know this as an enterprise risk assessment, but this was actually different in that it's truly a compliance assessment to look at where there may be internal gaps, not only in the compliance department, but across the organization where we may have issues where we have identified where we have low mitigation or controls in place. So this report is not intended to confirm violations. It's basically just to look at where we may have opportunities for improvement or where we may have gaps that could potentially become risk, and do we have controls in place to mitigate those risks. Rather than coming in and doing a full enterprise risk assessment, I wanted to start as a baseline because within our structure, we have not done a full compliance risk assessment. We've had several assessments that have been performed by different outside entities, which actually was included in this internal review for myself as well. But this was truly a look at how we can internally view our organization from a compliance lens. So in order to develop this assessment, the methodology that I used was to interview leadership. And then I also performed certain observations within operations. So I spent some time with different leaders throughout the organization, just talking about processes, things that keep them up at night, what's working well, what are some areas that you might see as a compliance risk in the future versus those where we need to focus on a little more closely. I also looked at, like I said, prior internal and external assessments. I looked at our regulatory guidance along with the OIG's guidance. So the Office of Inspector General outlines a work plan where they focus on every year annually, and then they issue a quarterly work plan. So I aligned what our clinical teams were focused on. We also have an internal coding department. We have a revenue cycle team that actually focuses on auditing our providers. They audit our medical records. And so I looked at the OIG work plan to make sure that we were focusing on the right audits. Are we looking at our coding reviews accordingly? And then the last part, I looked at the COCR gap assessment that was conducted for the compliance department. So this helped to make sure that we had a pure line of sight on our risk, and then it also helped me to drive the internal risk assessment. So one of the things that was very clear is that through interviews for those areas, I bucketed them in themes. And so we had some themes that were identical or duplicative across certain areas. So within the assessment, you'll see some areas that are that were considered as cross-linking, meaning it's the same risk resided in different operational areas. Everyone had like the same theme, or they had the same concern, and it kind of crossed departments. So in the risk assessment, those that were cross-linked to different areas, I bucketed those into one area and then looked at the mitigation for that. And then the tool actually assesses the ranking, right? So the methodology that I use within my ranking tool is the risk assessment, where the controls were in the department, if the controls were effective, and then ranked whether the control would help the likelihood of a risk occurring. So, for example, if a department had highly effective controls, but the area is just risky, right? The nature that we're in, the business that we're in, a lot of the areas that we deal with are just inherent high, right? And so the likelihood of an issue occurring is always going to be high. But if your control is really good and it's effective, then your risk becomes a lower outcome. And so in the tool, you'll see where everything is rated as high because of likelihood. But then when you bump in like controls, do we have effective policies Are our teams following those policies? Do our organizations know we have policies in place? The control becomes higher and then your risk becomes lower. So that's kind of how the tool was managed. In the tool, I had about 50 risks that I identified, but I dwindled those down to focus on those that were real, truly high-level risk. And in your actual packet, you'll see the actual risk and how those risks were rated. Let me see what page they're on, and I'll walk you through the ones that we identified. So on page 101, you'll see where I've bucketed those risks into themes across each functional area. And so a mixture of medium and high. These are the areas that fell out in the assessment tool where we really needed to come up with a mitigation plan because of just the exposure to our organization. So privacy and security inherently is always an issue that we need to actually focus on. Governance and oversight. So that's kind of what we've been talking about around policies, accountability, decision-making. Do we have authority structures in place? IT security, access and controls, again, inherently a high area. It's an area of focus for us and our regulators, and it inherently comes with reputational harm, high risk, and fines. So inherently that is usually always high. Financial controls, we have some manual processes, but our oversight is there, and so that one inherently is high. And then operational integration was one of the themes that was kind of across each functional area because we're integrating, we're growing at a fast pace, and so that landed as medium, but I thought it was one that lended itself that we needed to have mitigation plan in place and bubble that up for more exposure, even though it's not high. Again, revenue cycle, we're bringing on a lot of services, and so making sure that we focus on coding, denials, documentation, workforce readiness, that's all of the training that we're doing, all the HR, the integration, operational readiness when we do bring on new services or open up a new facility. So that was medium because we have some really good controls in place around that. And the last is business continuity. Again, another area that's always high, making sure that we have a good disaster recovery plan and business continuity plan in place. And so the report also walks you through what's identified as next steps. So the outcome of this risk assessment that I've created is we will be working on our compliance work plan and our audit plan. Those documents are intended, I think, to be presented on either the next board meeting or the one in June. But the board has authority to approve our audit and monitoring plan and our compliance work plan. So all of the items here are on a mitigation plan. And then those that are on the larger risk assessment that are like medium and low, they still lend themselves on our work plan, and we make sure that we identify a leader accountable for the risk, and then we have a mitigation plan in place. And then if you turn to page 102, you'll see a more flushed out next steps and management priorities plan. Taking all of the ones that I shared with you that are considered high risk, I've bucketed those into groups, and you'll see the work that's kind of intended to manage those risks. Again, these will be on the compliance work plan. Those that are considered truly high risk areas often land on the compliance audit plan. And so I won't go over all of these, but you'll see that for each one of them, we have controls in place to kind of manage the risk, and we'll make sure that we have a plan in place. So the next steps for this was intended to show you guys the work that we're doing around managing our risk assessment and then bringing the full compliance plan and audit plan to the next board meeting. And then also to address any questions that you may have around the risk assessment process and the risk that we've identified from a compliance perspective.
Nikia, when does I'm used to these audit monitoring compliance work plans where the board actually gives feedback around what areas they are worried about, and where is that kind of board leadership kind of review? Like, I'll give you my example. The one thing I don't see here, maybe it's in here, but to me, I worry about workplace violence and security for our staff and for our not for our buildings, for our staff.
And page
because there has been a trend in this country in workplace violence of like less numbers of them, but the ones that are there are much more high intensity and much more higher risk. And so the ability of the board to have line of sight to our policies and our administrative procedures around how we protect our staff from both patients, verbal abuse from our patients, or other kind of more serious efforts, I think is one that's important for the board to at least have knowledge about, not necessarily rising to the risk of an audit or a compliance plan, because I think you have to have the will of the board and see where everybody else is. But I just give you that as an example of when is the right time for the board to be providing some input. I'm grateful that you've got it all from the staff and from the leadership of staying up at night about particular issues. But that question rises because you've done a great job of doing the assessment, identifying the next steps and management priorities, but where do the board priorities come into play here?
I think that's a great call out. And typically, the way I would do this risk assessment so the baseline really just is your, you haven't done a risk assessment before, so you start with internal. But normally I would sit with the board at the end of the year. The risk assessment usually starts around like right before you start your the new year, so October, November, and I would typically sit with the board and get feedback, what risk should we focus on. So that's something that I didn't do for this baseline risk assessment, but noted, and I can actually fold it into this process because there's still there's two more pieces of this, and it's I wanted to engage the executive committee before the final risk assessment, work plan, and audit plan went before the board. And so there's still opportunity to sit with the board and interview the board and find out what risk you kind of want us to focus on. I think that may be a good next step.
Thank you. And I'm just going to go around the room for see if it was one
Maron
round.
had her hand up first.
You want to start, Maron? Yeah, Dr. Brinson.
No question.
No questions, Manager Valadez?
One of the things that I would like to know is how the plans that have been put in place and the protections that have been put in place, how are they flagging the risk? So let's say somebody hacked our system. Mm-hmm. How is that being flagged, and how quickly is that coming to us? We have, let's say, as our chair talked about, we've got a possible assault on a staff person going into their parking lot. How is that? A fox has gotten loose under a car, is going to attack somebody. How is that? Is there a patient? Maybe patient-on-patient violence. I mean, those kinds of things. How are they being flagged? How are they being recorded? And when does that come to us?
Okay, that's two questions.
Because to see whether or not there is maybe something systemically that we need to do, or whether it's just, a fluke or whatever, or maybe an additional security component needs to occur in this area, or even if there are trends that can be drawn from whatever your reports are providing you. That information, I'd like to know that.
Awesome. So we have a system in place today that's managed by our, it's twofold. One is managed by our safety officer, and then some of the cases also come to compliance to handle. So all the clinical teams they go in this system, they log incidents. So if an incident happened in a facility, they would go in the incident response system, put the case in there, and then it would feed to the respective areas. Today, there's someone on my team that manages that, and then along with the safety officer. And collectively, we manage those cases, we investigate those, and then there's reports. I think that the piece that may be missing is bringing those reports to the board for more visibility, but we are managing those, and they're managed in a system. We have report outs, we have follow-up, so those are being handled.
I like that, but I'd personally like to know if we've got some issues that maybe we need to be made aware of as a board for the system, in light of the fact that we're transitioning so quickly, and we're going to be, God knows what it's going to look like at the hospital, once we get our additional clinics online. So thank you. I appreciate that.
And we've talked to Nikki about how to do maybe quarterly reports to the board, written ones about kind of some of these issues that come up, because The board just has to have line of sight to that, not a role, but a line of sight to that. I'm gonna move on, Manager Velez, to Manager May. No questions?
First and foremost, Nakia, thank you so much. I know there's a lot of work here. And I think you've done a real good job of really organizing what you have, what you're working with, and then organizing the needs of the board. So thank you for that. I'm just gonna ask you a real basic question. With respect to what we have in front of us, both from the perspective of the policies that you just reviewed in terms of all the numeration that we would have to be doing, reviewing as a board. How far along do you think we are in this process as far as time? And the reason I'm asking is because I feel like since you came on board, you have really fast forwarded this process. And I want to say you've probably have shaved off a good 2 months, 3 months off the deck in terms of if you were working on it under other circumstances?
Yeah.
You have, haven't you?
I don't know if it works. I did. Well, you're right. So normally things would progress in a different fashion, right? You would have your risk assessment at the end of the year, then you would work on your audit plan, your monitoring plan. But because we're in a build year, I feel like this is a build year for me and my team. We're really working foundational, right?
Yeah.
And so that's why when you remember when I first started, I said give me time because it will feel a little wonky, like things won't come. It's like they normally would progressively through the year, like you normally have a calendar that looks and feels a little different. So it may feel out of order, but this really sets our foundation. And it was important for me to do the risk assessment, right? Coming in to make sure I understood from my perspective where we have gaps, where we have really good controls in place, and where we need to prioritize our efforts, because this really helps frame our work for the rest of the year. But you're right. It is work. We're working a little backwards, but I think we're making progress.
But you're making progress.
Yes.
And the reason I'm asking is because on the one hand, I'm asking it to give us a feel for the board, to have a feel and appreciation of the work that's being done. Not that we're not, but I really, having done this work myself for state agencies, I know how laborious and time-consuming it can be, and sometimes like it just doesn't move very fast. That being said, I feel like you've taken. I think you're going to have this process done, at least the beginnings of it. You'll have, in 6 months, we'll have a real clear idea of where we stand. I just feel you're at that trajectory with this. I could be wrong. So I just kind of want to share that with our colleagues so that, not to set you up, but I think it's coming is what I'm saying. I think it's coming at a faster pace.
It's coming together.
Yes, and it's coming. And then I also wanted to say that, not that it's neither here or there, but because of the sense of urgency that we were seeing back in the fall when we started looking at all of this, I remember sharing with Dr. Lee that I thought that at a minimum, because I couldn't see, that you were coming on board. I just didn't know what the plan was internally. But I remember at one point even saying to him, this is going to take a 12-month process. I think you're going to have to hire somebody from the outside to begin the work so that we can get our work done as a board. So I'm real happy to see you here, and please keep it up because I know that you're moving this along and you're organizing it in a manner that I think in the end is gonna pay off. So thank you.
Thank you for that.
Thank you, Manager Mercedes.
Thank you, Nakia. One thing that caught my attention is the IT. We've had several breaches, several things, so I'm just wondering, following those incidents, what corrective actions were put in place? You don't have to answer right now, but it will be helpful to know what was done and what needs to be done and enhanced and improved. Because to me, we've had issues, and I just wondered.
They were serious.
Yes, absolutely. As we're moving forward, another thing, I think something to hone down on with staff. Sometimes when you're getting audited, sometimes these audits come unannounced. That you need to be very well prepared. I remember once, like Jayco came, whatever, like you need all documentation, and I had one who actually was an expert in the field that I was working and went through every single document for documentation. So that's the type of training as staff is evolving into a early documenting and process. Just be prepared, and not so. Again, appreciate the work that you're doing, and we're on the path of moving forward. But there's a lot of work ahead of us, and I know under the financial parameters, if there's something my committee needs any to chime in, please let me know, and we can coordinate if there's anything that we need to do. Thank you.
Thank you so much.
Chair, may I offer a response on the cybersecurity? Just
Sure, briefly. 'cause
briefly, it is critically important, Dr. Misaitif. And so what I can assure you is a very thorough review has been done to make sure we have the most advanced practice, including three-factor authentication. YubiKey is now system-wide. You have to have the password, the physical presence, right, and the facial recognition to log in. That's the maximum security. We also independently hire hackers to try and find vulnerabilities. They always find something. They actually didn't find any this time, which they say is extremely rare. And then every time we try to open an attachment or click a link, there is a filter that's constantly even testing, do you think this is safe? And oftentimes it is safe, yeah, but it's testing, giving feedback in real time. And so we are tracking billions of threats that are coming in, and they are not getting through our defenses in the current state. So I just want to call that out. Very, very important point. Yeah.
Yes, we're doing a lot of work in that area, and we even have a third party that's managing our system, monitoring it continuously, and I actually meet with them a lot. We spent a lot of time together over the last few months, and they actually send the reports to us, and then we also follow NIST framework for our security audits. They've been working with compliance for those. Our privacy officer works with security officers, so that's an area that that really has a lot of work, progress has been made.
Imagine when we look at the policies, we might look at how we're notifying the board about these issues, because we don't necessarily have a role to play other than the policy piece, but it's good just to have line of sight to notices about that, especially around HIPAA violations, especially if they become large, then you're required to go out and give notices to patients' records. But there's a lot here that we need to, when we get on a cycle of these policies, we'll be able to get ourselves educated on some of the more specific issues of that. Dr. Morton?
Nakia, thank you. Very, very good work, and I appreciate it. I'd like to just second Manager Rodriguez's comments concerning board priorities, and I think you've addressed that well, so thank you.
Thank you.
Manager Jefferson?
So the chart that you have where you identify the risks and the risk levels, all that looks appropriate to me. I want to just, the last section where you talk about next steps and management priorities, and you indicate what the next step will be for this fiscal year. And just to kind of hearken on what Manager May was saying, it seems like it's a real ambitious goal. I guess I'm probably more familiar with there being, is this compliance function similar to an audit plan? And let me say, I know that there's reference to your inputs, including the Mazars review and then OIG work plan, and I didn't know whether that's an OIG of Health and Human Services. They're using that as a sample document, or whether we have an OIG that we're talking about.
No, the Office of Inspector General actually has guidance around effectiveness around compliance programs, and they've laid out what your compliance framework should look like and whether it measures effective. And so everything that I've outlined here follows that framework. There's 7 elements of an effective compliance program, and this is one of the effective of the 7 elements: having a risk assessment, an audit plan, and a work plan. And so in order to have that framework in place, you have to have a work plan and audit plan, and you have to do that by conducting a risk assessment. So this is like the beginning of that process, if that makes sense.
So this is the beginning, and then there's a plan?
Yes. So
the plan, I guess the format I'm kind of used to seeing is that the plan is proposed to, whether it's the Audit and Finance Committee or the whatever, and then it's approved there, and then it's acted on. And quite frankly, it's not that many items that's worked on for that particular fiscal year, because it takes time.
Yes.
And so I'm a little concerned that we're kind of halfway through the fiscal year, and I'm wondering, I'm used to it being proposed to the board, a subcommittee of the board. This is what we propose to do as the researching group,
Yeah.
and then
I mentioned that it was good that I have I have a plan ready to bring to the board.
Okay.
So I have an audit plan that I've created as an outcome of the risk assessment. Currently, I have about 12 items on the list, so a little aggressive, but it takes us through this year and the beginning of next year. Remember, I'm starting in the middle of the year, so it's a little off. But I have an audit plan to propose to the board based on this work. And then I also have a compliance work plan that has all the things that we need to get accomplished. And again, it's going to roll over to next year just because of where we are in the year.
Okay, that makes sense.
And so
to me.
that plan is intended to bring to the board as an outcome of this. I will tell you that it depends on your structure and your maturity, right? If you have a functioning audit committee, then your internal audit plan will go to them for approval. But the way we have the compliance program framed currently, most of the compliance items will come to the executive committee first and then go to the board for final approval. I did not have the audit plan routed to go to an internal audit committee yet.
No, that's fine.
So the
Executive
board
committee's
will
fine.
see those, yeah.
But the key thing that you
Yes.
said that makes me feel
Yeah.
comfortable is that it is coming to the board
Yes.
for the actual plan. And then the other thing that I would like to point out is when you bring that, as a board member, I would like to know, I'm one of the new ones. I guess I'm the newest one on the board. And so there's been talk about the Mazars review, like everybody knows what those
Gotcha.
to-do items were. I did look it up when I was sitting in a meeting where it was being reported to the county commissioners, because I didn't know, and I felt really like I was kind of behind the eight ball. And so I think those items that we're supposed to be acting on should be very present in the board's, when these kind of materials are coming through, so that we know what we, I guess, committed to follow through upon.
Yes.
So that would be my ask. But anyway, so this is a framework that will form the basis of a plan. And so,
Yes.
okay, that
So the
sounds
outcome
good.
of
And
this
just,
assessment-
keep it reasonable, because we're halfway through the fiscal year.
Yeah, we will have one, but the outcome of this is the compliance work plan, a risk-based audit and monitoring plan, and then also, what was I gonna say? There's also, I've linked in the work plan, items that are tagged for follow-up because of the Mazars review. So, there were several things that were identified in there. So there are a few things that fell on the audit plan because of that review that I followed up on. But there's an item in my work plan to, go back and validate some of the things that we said we were gonna do. But it's three elements to that. One is to make sure that we, have controls in place for those items that we said we were going to address. And then the second layer of that, I was gonna go back and audit those areas that we marked as complete. So, for example, if we said we created a work plan for cybersecurity, then my team will go in and look at that element to see if it's closed or not. And I actually just talked to the person that's managing Mazars, and we have a meeting, scheduled next week, but that is on my work plan.
And the other thing is, mention was made of privacy and security, and I think it's really helpful to use some of these outside audit firms who are used to that, because they have the tools to find problems, as opposed to, I think they have the more sensitive
Yes.
tools to ferret out your vulnerabilities. And I hope we're taking advantage of that kind of expertise that exists outside, by those outside experts.
We do. We have a entity that's doing that work for us, that monitors our system. The entity, monitors our system continuously. And that's the work that, Dr. Lee and I spoke about, earlier. They're a third party, and they actually just gave us a quarterly report. And they,
It's monitoring, but auditing. There's
there's an audit component
that
to
can
it
be
as
done.
well. They're actually going through like the annual security audit right now for us.
Manager, after that, I think one of the things you reminded us, and I think Vice Chair and I were just talking, that we probably should put an update of a Mazars audit on the June agenda for the board, just to give us an update about where we're at, because I having been on this board the second shortest time, I don't recall that we've had an update on Mazars. Is it Mazurs or Mazars?
It's
Mazars, sorry.
I think the last time we had one, sorry. I think the last time we had one was a year ago this fall, this past fall. Because I remember receiving it once, but that's it. So we're way overdue for one, way overdue.
Manager Kitchen, any questions before we move on to our next item? No questions?
No question.
Okay, so Nikia, you need a motion to approve the annual compliance risk assessment as recommended?
I thought this was informational.
Is it information only? Oh, great.
The motion is to that I can take the risk assessment to the full board.
Oh, I see, that we need a motion, members, to recommend to take the annual compliance risk assessment to the Board of Managers later this month. Do I have a motion? In June, yeah.
In June or in May?
I'm sorry, in May 27th, yeah. Yeah, for May 27th, no. There's a motion, I don't know that we need a motion. There's a sense from the board that we're gonna move this item to the Board of Managers.
Just to take it, if she's just gonna bring it back and the board's gonna vote on it, you don't need a motion.
Yeah, okay, great.
It'll accompany the work plan and the audit plan.
Got it, okay. No motion needed. Okay, members, I'm gonna, it's 7:35 PM, and I announce that the committee is convening in closed session to discuss agenda item 7 under Texas Government Code 551.071, consultation with attorney, and agenda item 8 under Texas Government Code 551.071, consultation with attorney, and Texas Government Code 551.074, personnel matters. And the date is May 13, 2026, and it is now 7:36 PM.
Could you read the two items?
And the two items, the two items are agenda item number 7, receive and discuss a briefing regarding Travis County Healthcare District doing business as Central Health versus Ascension, Texas, frequently known as Seton Healthcare Family, cause number D1GN23. And then agenda item number 8, deliberation and possible action on the appointment, employment, evaluation, reassignment, duties, discipline, or dismissal of one or more Central Health employees. Good evening. It's May 13th, 2026 at 9:36 p.m. and we are entering our open session. Managers, our next executive committee meeting is tentatively scheduled for Wednesday, June 10th, 2026 at 3:30 p.m. at Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas, 78702. At this time, I'm ready to accept the motion for adjournment. Manager May makes the motion, Manager Valadez seconds. All those in favor of the motion, please raise your hand and say aye. Motion passes. The passes unanimously. And it is now 9:36 p.m. on May 13th, and we are adjourned.